Do it. Hey, thanks so much, everybody, for joining us here at Georgia MemoryNet Insights. Glad to have you today. Ted Johnson here. I'm going to introduce our speaker, Dr. Chad Hales. Dr. Hales is a physician scientist here at Emory on faculty as an associate professor. He's a board-certified neurologist. He directs the cognitive neurology clinic here at Emory and is also the lead of Georgia MemoryNet's memory assessment clinics. And so he's a thought leader, and I've called this a graduate course in diagnostics. And so looking forward to it. He's going to tell you what quacks like Alzheimer's, looks like Alzheimer's, but might not be Alzheimer's disease. Over to you, Dr. Hales.
Excellent. Thanks, Ted. So Chad Hales again, and you can see my title. I think Dr. Johnson put it appropriately with the duck analogy. A couple of obligatory slides here for the accreditation and CME. Disclosure statement, which I'll show on the next slide. I do participate in industry-sponsored clinical trials, which are routed through Emory, and none of those have relevance for the discussion today. So what are our learning objectives? So the main goal is I thought it would be a good opportunity to chat about clinical mimics of Alzheimer's disease, because I feel like we often get stuck in a pattern of seeing our patients in the cognitive clinic and thinking quite commonly that, well, common things being common is probably Alzheimer's disease if they have memory loss. But my goal is, by the end of this discussion, is to show a few other causes that may look like Alzheimer's disease, not to frighten you, but just to make you aware, so that when you are seeing patients, you might take half a second here and there to say, is this Alzheimer's or could it be something else? So the goal will be to recognize these clinical mimics, maybe define a few clinical characteristics, particularly related to age, and then describe some diagnostic tools that might help you as you're trying to discern whether or not it's Alzheimer's disease or something else. So I'm not going to present a lot of patients, but all the patients that I will chat about have a common theme in that they have memory loss. And by memory loss, I mean they're repetitive, they forget recent events or appointments, not really having trouble with language or executive tasks, but we recognize that some patients with Alzheimer's and other disorders can have impacts to those other symptoms and cognitive domains. But for the discussion today, when I say memory loss, it means trouble encoding new pieces of information. We'll also keep into account that the patients we're talking about, that they're typically independent. So these are patients that are in that early type of symptomatic phase and likely have mild cognitive impairment. So memory loss, when I say memory loss, I mean memory loss, not memory loss, I can't pull a word type thing. We'll start with Alzheimer's disease, right? And I just wanted to show this slide because it highlights an important piece for Alzheimer's disease. And you'll see for Alzheimer's, I have age greater than 40. And the reason and really that number could be 30 and actually could be 20 because there are some cases of early onset Alzheimer's disease that have been reported very early in life. And those are people who have the autosomal dominant mutations that cause Alzheimer's and more early onset, whereas we typically think of patients presenting later in life with late onset. But a common feature is memory loss for the most typical presentation, and you often see changes in the brain. And so in this particular case, I'm showing you a series of scans that show some progressive mesial temporal lobe atrophy. You'll also note that there's some generalized brain atrophy as well, because when you look at the lateral ventricles, you see those are getting larger as you're seeing atrophy out on the surface. So common feature, Alzheimer's disease, you've got some hippocampal atrophy and some generalized atrophy. How do we diagnose Alzheimer's disease? For those of you who may have attended a talk before, I've talked, there are a couple of ways to confirm Alzheimer's. One is with a spinal fluid study, and the other is with amyloid PET imaging, where we actually label amyloid in the brain. And showing you a couple examples here, negative scan versus positive scan. And there are several different agents that are available, or ligands that are available on the clinical market. So spinal fluid, A beta 42 and tau assay, or amyloid PET can help you as you're thinking about underlying Alzheimer's disease if that level of suspicion is high enough. There's also a lot of chatter recently about plasma tau, which I talked about last time at GM Insights. And that's important, right? We have this as a screening tool, and eventually it's going to start to replace some of the spinal fluid or amyloid PET. We're not there yet, but I feel like we're probably getting close. And many of you may recognize that 3 or 4 weeks ago, the FDA approved a version of the plasma tau 217 and A beta 42 ratio assay. Not currently available commercially, but will eventually make it into the mainstream. And I suspect that may help kind of push things a little bit into the blood-based biomarker process. This is showing you one example of a plasma tau assay, and this is measuring just the plasma p-tau 217 and showing you that the area under the curve and the sensitivity for these assays is pretty good. And of course, this is if you use a single cutoff of 0.229 for this particular assay. If you actually use a dual cutoff, and let me just have you focus on panel C here. So if you're less than 0.185 on this assay, then you can see that you're on the lower side for an amyloid PET scan. So this is the value of the amount of amyloid in your brain. So this is a negative amyloid PET scan and a negative p-tau 217, whereas if you're above 0.324 in this particular assay, that's a positive plasma tau assay and a positive, which will be consistent with a positive amyloid PET. And so these are really good studies, useful in the clinical diagnostic algorithm, and certainly gaining more traction. So that's Alzheimer's disease. So memory loss, you're looking for diagnostics and thinking about, well, could it be Alzheimer's, and going down the route of, well, these are the biomarkers I'm going to use. And the reason that's important, right, for identifying Alzheimer's is we have disease-modifying therapies. There are therapies that are available. Granted, the clinical efficacy of those is limited in some patients, but there are likely some patients who do benefit. And so that's the rationale for clarifying that diagnosis. But what if it's not Alzheimer's disease? And so let me show you a couple of examples here of, of images. Okay. So the first is this patient up here. And you can see both of these are on the older side, right? For Alzheimer's disease, I had mentioned could be as young as their 20s, 30s, 40s for early onset. For late onset, as you know, that can be anything really from 50s all the way up. But here I'm showing you a couple of patients on the older side. They have hippocampal atrophy, right? You see lots of loss of that hippocampus. You see a little bit of generalized atrophy. But this patient here, they have a negative amyloid PET scan. And to have Alzheimer's, you have to have amyloid in your brain. They also have a negative tau PET scan. So this is labeling the other protein for Alzheimer's disease. And so both of these are negative. So if you have a 86-year-old with memory loss, again, difficulty encoding new information, shrinkage in the hippocampus, and no amyloid or tau, it's not Alzheimer's disease. And similarly, you can have people who have a same profile with amyloid, but without tau. And so you have to have the tau component for this to be Alzheimer's disease. And you might be saying, well, so what's causing the problem? If it's not Alzheimer's disease in this older patient, we know they have hippocampal atrophy. What could it be? And this is the entity called late. So we think about that impacting patients as they get older. And when you actually look at this, this is a great article which walks you through the concept of late. So feel free to take a look at it. But when you look at neuropathological findings in a large cohort, it accounts for 17% of some of the pathology in these cases. And so it's not rare. That's the bottom line. It's not rare. You have Alzheimer's, you have vascular changes, and then you have late, perhaps even more common than Lewy body pathology. So this is something that we're identifying more frequently now because we're doing more biomarker testing on people and finding patients in their 70s, but mainly 80s, that don't have amyloid or tau, but do have these findings of neurodegeneration and memory loss. And so this is late.
Hey, Chad, could you just set up the ATN classification and just familiarize folks with those abbreviations,
Yeah,
please?
I can briefly speak to that. I wasn't going to wade too much into it, but the concept here is amyloid changes in the brain, tau changes in the brain, and neurodegeneration. And so this,
Perfect.
yeah, so just are you seeing all those elements or not? And this is a way of kind of classifying patients as they come through the clinical setting. A similar entity is called PART, primary age-related tauopathy, which if you look at case series for this neuropathological, if you live long enough, you will have some of these tau changes in the middle part of your temporal lobe. The difference for this is that it typically stays isolated to the middle part of the temporal lobes. And we really only identify this in people who are older, who have some changes in the hippocampus and who die. And you basically see that they don't have amyloid, but they do have some tau changes. Late may be the more common, but hard to know on the PART side. First question. So late and PART should only be considered a diagnosis of exclusion in older patients with memory loss. True or false? And I think a poll might pop up. And it looks like as a host and panelist, I can't vote.
It's for everybody else to vote. And Kim is watching the poll, and she'll close it when we start tapering off on new responses.
No problem.
While we're waiting for the poll to close, just pointing out that there's a question and answer box. And so I'm monitoring that. As soon as you drop any questions for Dr. Hales in there, we'll tee him up for those. Thanks.
All right, excellent. Thank you all for responding. So late and PART should only be considered a diagnosis of exclusion in older patients with memory loss. So this was a little bit of a tricky one. I used the word only in there, which most people would say if you see only or never or all those, then it's always going to be false, right? But in this case, the answer is probably true, right? Because remember, we have disease modifying therapies for Alzheimer's disease. And so in these cases where you see hippocampal atrophy, memory loss, you're probably going to want to look for Alzheimer's disease first. And if you find Alzheimer's disease and they otherwise meet criteria, then you may want to put them on one of the therapies for Alzheimer's disease. If you find that the biomarkers are negative, then you can start to postulate that maybe late or PART is present. Now, it gets a little tricky and nuanced when you find some positive amyloid, but they're also in their late 80s. You can't say for sure what percent of the amyloid is contributing or if they have later PART. And so that's the part where we're still limited because we don't have good blood tests or other ways to measure late and PART in the brain just yet. We're still limited by that. We can look at a piece of your brain under the microscope, but typically don't recommend doing that until you're done using your brain. Next condition. So age greater than 40 is typically what we see for this one. Again, person with memory loss. You can see in this case, I'm showing you a couple of MRIs. We'll focus on this right image first, which shows, well, kind of one of the things we're looking at, hippocampal atrophy, right? A little bit of entorhinal cortex atrophy, a lot of entorhinal cortex atrophy on this side here. And you can see actually a little bit of temporal, anterior temporal lobe atrophy as well. Another case, similar condition, a little bit more progressed. So here the hippocampus and entorhinal cortex is pretty devastated, right? Really tiny hippocampus and knife edge-like atrophy in the anterior temporal lobe, which you can see here on this sagittal image on the left, as well as on this coronal image. You can see lots of this extra black space where spinal fluid has taken in, where there's been some atrophy. Now, this is a condition, not Alzheimer's disease, not later PART, typically on the younger side, but due to frontotemporal dementia. And so this is another article I would encourage you to look at. Let me orient you to it, and particularly this chart here. And this is actually showing a cohort of people with frontotemporal dementia who carry mutations in the microtubule-associated protein tau, MAP-tau. This is the same tau that accumulates in Alzheimer's disease, but they're typically not mutations in tau in classic Alzheimer's disease. This is the mutation described as R406W. This describes the location in the protein where you have an amino acid substitution from R to W, okay, arginine to tryptophan. Now, this cohort includes 21 people in it, and all of these people had MAP-tau R406W, And they are showing you that there are actually two clinical presentations of these people. One is behavioral variant frontotemporal dementia. These are patients who get disinhibited and have that kind of more classic behavioral based presentation. And the other part of the cohort, which you can see was actually more than the behavioral variant, had an Alzheimer's disease clinical phenotype. So these are people who were labeled clinical Alzheimer's disease who actually turned out to have mutations in MAP-tau due to frontotemporal dementia in this particular site. And when you look at age of onset as well, same article, the people with the Alzheimer's disease presentation were perhaps a little bit older. So this is age at onset, a little bit older in their early 60s, whereas the behavioral variant group was was more in their late 50s. And so you can see there's a little bit of a trend or shift towards younger age, but perhaps not as young as you might see for the early onset Alzheimer's with those mutations that cause Alzheimer's disease when patients are in their 40s. So this is something that could start to pop up in the clinical practice, because if you look at the range, some of these patients with the Alzheimer's phenotype, they're getting up into their 70s, which is where you might start to suspect people having issues, even 60s or 70s, start having trouble with Alzheimer's, true Alzheimer's disease. So this is an important one to think about. And when you're trying to decide if this is present, there's a couple of things that are important. One is the brain imaging, right? Oftentimes the brain imaging is pretty significant for the patient's age, particularly in the mesial temporal lobes. That's one. The other, this is where your clinical history taking skills are really important. So you want to ask about family history. In family history for these patients, there's typically several generations and of course multiple people within a generation that have Alzheimer's disease, dementia, something along those lines. And you want to see 2 or 3 generations of this to kind of start to pique your interest. But if you see MRI findings that just look really pretty devastating and you're not really sure on the family history, it's worth entertaining this as a consideration. Okay, second question. When considering late Alzheimer's disease and FTD MAPT, FTD is the only one with a strong family history. True or false? All right, oh, excellent. So this one I didn't trick you on. So here the only was a key, right? And so FTD is not the only one with a strong family history. I don't think we know enough about late yet to know if there's a strong family history. But for Alzheimer's disease, there can be, and particularly in patients who may have genetic risk susceptibility factors such as ApoE, and particularly the E4 copies of apolipoprotein E. And so you can see some strong family history of Alzheimer's disease, both late onset with the risk susceptibilities, and particularly with the early onset Alzheimer's disease when patients have mutations in amyloid precursor protein or in presenilin 1 or presenilin 2. So there are other entities that can have a strong family history, and it really just speaks to the importance of taking that family history when you're seeing patients with cognitive impairment, because sometimes you may find the diagnosis just by doing the family history. And of course, I have a great example of that where the patient was presenting with a behavioral variant frontotemporal dementia, and it turned out one of their siblings actually had died of ALS. And of course, we know that there can be motor neuron overlap or ALS overlap with frontotemporal dementia in patients who carry a specific mutation, especially in something called the chromosome 9 open reading frame 72. Big mouth term, big mouthful, C9orf72. So family history is important. That's the main point for this particular question. The last process that can cause memory loss, remember we've talked about Alzheimer's disease, we've talked about latent part, we've talked about frontotemporal dementia due to R406W, all of which can present with a clinical symptoms that look like Alzheimer's disease. This is the last and most curious one I'll chat about. And introduce a couple of terms for you here. One is this term LGI antibody encephalitis. LGI is a protein, okay? It was previously referred to as voltage-gated potassium channels. But in this particular case, your body makes an antibody that attacks some of the receptors up in your brain. And that causes a problem when it binds to receptors that it shouldn't. And it can cause inflammatory process that can cause this syndrome. This particular article is good. The age can be greater than 18. So this is a very wide range of people that can be affected. But you'll see the age at symptom onset for this cohort of 118 patients with LGI and antibody encephalitis, age at symptom onset, 66 you can see the range here. So you got the median. That's getting close to Alzheimer's disease age, right? And so it is high. And of course, some of these in their 80s, you're in the Alzheimer's disease range in your 70s and 80s. And so that's why it's important to at least ponder this when you have a patient presenting. And of course, one of the important pieces here is there are often other associated factors, but sometimes the other associated factors are not present until several months into the syndrome. And one of those factors is seizures. One of the more common types of seizures is something called faciobrachial dystonic seizures. Again, kind of a big mouthful, but if you see it, it is almost pathognomonic, which means if you see that in the context of a patient with these clinical symptoms, it's classic. And what happens is you'll have just a tiny little smirk in the face and a jerk of the arm. And it's just like that. It lasts just a couple of seconds. You go, and it'll be just that quick, but it can occur hundreds of times per day in some patients. And so this is why it's important. The catch is you want to try to catch this before they reach the stage where they might develop seizures. And so you might be saying, well, how do I know that if I have a patient who has memory loss, but I don't yet see seizures? How do I know if they have LGI encephalitis or an autoimmune encephalitis? And here's another term, Casper-2, which is another antibody, which kind of gets lumped in with LGI. Okay, these are kind of the same phenomenon. But the way you can pick this up is imaging. And so this is a great article which shows you the changes in LGI encephalitis in the brain. And let me focus you on this top panel here. So for LGI and Casper-2, this is in a cohort of patients. You can see that almost all of them had changes in the hippocampus. There were some changes in the entorhinal cortex and maybe a little higher up in the temporal lobes, but the majority had changes in the hippocampus. And you might be saying, well, what changes do you see? And they can be very subtle. And the main change you might see is a little bit of T2 hyperintensity. This is a FLAIR image, okay, for the MRI. This is a coronal image, which is not standard on most MRI protocols, which can make this hard to pick up if you're just using axial FLAIR images. But you'll see just this subtle increased T2 hyperintensity, which could suggest a little bit of inflammation, a little bit of swelling in that part of the brain. Sometimes you don't even see enhancement with that. So it might not even look like it's an active process. But this is what you see. And of course, I don't have time to walk through some of these other things that can cause T2 hyperintensities in the temporal lobes and can cause rapid progressive dementia. But the concept here is if you see somebody with memory loss and you're thinking Alzheimer's disease, take a quick second to look at the FLAIR and the hippocampus just to make sure you don't think they look too bright. Because if they do, then this is where you want to kind of trigger additional testing that may be helpful in your diagnostics. And in this case, if you suspect it based on the brain imaging, then you're going to want to do blood testing and perhaps spinal fluid testing to look for those antibodies that bind to the LGI1 and the Casper-2. Final question. Seizures like faciobrachial dystonic seizure are common in LGI1 autoimmune encephalitis. True or false?
While we're waiting for the answers, feel free to put questions in the chat. I'm sorry, in the question and answer box. And here it comes.
Yes, good learning, good learning. So absolutely, so you can definitely see these, and when you see them, it's pretty clear that you may have something else going on. And what can happen with those patients is that can be an initial manifestation, but they may also present with generalized seizure as well. And so that's why it's something to kind of keep an eye out for. So last slide. I took you on a whirlwind tour of things that can cause memory loss that look like Alzheimer's disease. Of course, you got the standard Alzheimer's disease. Then you have the typically maybe more age-related pathologies like late or part that we think about as patients get into their 80s and 90s, but may not have underlying Alzheimer's pathology. We talked about a variant of frontotemporal dementia with mutations in the tau gene, particularly the R406W, which causes highly focal atrophy or shrinkage in the mesial temporal lobes with an age of onset that might be a tiny bit younger than your typical Alzheimer's patient, but not by much. And then finally, we talked a little bit about the LGI1 and Caspr2 autoimmune encephalitis, where your body makes antibodies that bind to things that it shouldn't in the brain. And those patients, you're going to be looking for some of the T2 hyperintensity or brightness of the hippocampus. And of course, if there's evidence for seizure or those kind of faciobrachial dystonic seizure, then it's going to kind of pique your interest for that. So you've got MRI that may help you a little bit with differentiation. You got age that may help a little bit. And in some cases, you may have genetic testing that you could potentially do for those frontotemporal dementia cases. So thanks for your time, and I'll take any questions if there are any.
Chad, that was a masterclass. Really appreciate you. Charlene Jeffers has a question, and if you could find that, I'll answer Dr. Somayila-Jula's question via typing.
Yeah, working. The question is there any variation other than memory loss that could be captured on neuropsychological testing between these conditions? Oh, that's a great question. And the answer to that is it depends on how early the patient presents, right? If the patient just presents at the first sign of symptoms, the answer is maybe not. You might just see some amnestic features noted on the neuropsychological testing. As we all know, it's often difficult for patients to present early enough so that they just have an isolated memory deficit. And so more often than not, you're probably going to see other findings, just like we often do when patients present with their MoCAs in the low 20s and maybe they're amnestic or show memory loss on the word list task, but maybe they're starting to show a little bit of difficulty with fluencies as well. Certainly for the frontotemporal dementia case, those patients can also start to, because they blur the lines a little bit with the clinical presentation of behavioral variant and Alzheimer's disease clinical variant, that sometimes you might pick up on a little more executive function that could be helpful on the neuropsych testing, but it really just depends on how quickly they present. Are there geographic clusters of these conditions, such as with Parkinson's disease? So late, I'm not aware of. The LGI1, no. I mean, that is something that appears to be just kind of all over. And then from the FTD map tau for R406W, the answer is that's an interesting question because there are some areas where there are families that are located who have that underlying mutation. And depending on where those families are, you may have a higher prevalence than what you might expect to see in the general population. And usually the only way you might pick that up is if you identify a couple of cases in the local area. I don't know if there's any numbers on it because it's still a pretty rare disease, but it is something to keep in mind.
Hey, Chad, could you maximize the slide that shows how to get credit for this while you're just answering this last question from Dr. Mims?
Sorry, did I deleted it?
No, that's okay. It's just, they were perfect. That's perfect. And then Dr. Mims has a question.
Sorry. Another question, is the primary value of this differentiation is to exclude people from monoclonal therapies? Ooh, good question. So The primary value is actually a couple of fold. One is the one you mentioned. It's important to identify people who may have Alzheimer's disease and may benefit from amyloid monoclonals. The prognosis for some of the others, certainly with later part, they're going to be older patients. There's not a whole lot that can, at least that we know of, that can be done. For the MAPTau R406W, no therapies yet. However, there are observational studies which are kind of putting together a research trial, clinical ready cohort. So identifying those patients, if they're interested, is important so that they can get plugged in. And finally, the one you don't want to miss is the LGI or Caspar-2 encephalitis, because if you can identify those people, then you can fix them. This is an opportunity to fix the patient if you get them on immunosuppressive agents. And that includes plasma exchange, other rheumatological based agents, some steroids. Most of these patients go into some level of remission once you treat the autoimmune encephalitis. But I will tell you, I personally have an example of a patient who I took care of who had LGI1 encephalitis, followed him for several years, started to have symptoms again, worked him up. The LGI encephalitis was not present, but he had developed Alzheimer's disease. And so you've got a patient who started out with LGI and then went on to develop Alzheimer's. But that's probably the big one, is you don't want to miss the opportunity to treat. And you might say, well, will they present anyway at some point? And the answer is the LGI, the natural history and progression that we know of is that most people will have several months of memory issues, and then they'll go on to develop some of these other symptoms, including seizures. And so they'll eventually present to a hospital, but by the time they present, it could be after a lot of damage has already been done. So that's the one you don't want to miss and keep your radar up for.
Dr.
The
Hales, thanks so
website.
much for a great class. And that last question is from BJ Scott. And we're going to send out something to everybody via email, just as a thanks for attending. And if you don't do the text message for credit, then there's another way to claim credit. I'm going to just share screen for just 1 second, because I think that this is a really interesting and important late breaking development. And that's that this was in response to an earlier question about where can you find these past recordings. If you go to YouTube and you type in Georgia MemoryNet playlist, you will find the first hit being GM Insights. And so that's a great place to look outside of any wrappers or online courses, to just go and say, hey, look, I wanted to catch this one that I missed. Hold on for a second, because I'm going to show you something else that you might be very interested in. This is also Improv for Caregiving, which is newly live on YouTube. It is a collaboration between Georgia MemoryNet and the Dad's Garage Theater and Improving for Improv and Georgia State University. Fantastic tips on how to use improv as a care partner. And they're each like 2.5-minute videos, and there's 18 of them. So just trying to bring you value here from Georgia MemoryNet. Hey, thanks so much, everybody, for joining. Really appreciate you, and we'll catch you soon. Go ahead, Kelly.
Dr. Johnson, Kelly Chapman has her hand raised.
Okay.
I think she may, well, she put her hand down. So I guess everybody is logging off now. I didn't know if she had a question or not, but maybe it was already answered.
Thanks so much for watching it, and appreciate everybody. Thanks again.